Welcome back to another episode of Hormones Happen. I'm your host, Jeremiah, also known as the Optimized NP on TikTok. I've got a real special guest for you guys today. She's an NP that specializes in gastroenterology, Sarah Gallegos. Thanks for being with us.
Yeah, thanks for having me. It's really exciting.
Yeah, I've been trying to get you on here for a while. Me and Sarah go back. You can almost say trauma bonding back to the ICU days. But for all the listeners, Sarah, tell us a little bit about, how long you've been an NP, what you've done, some of the things that you enjoy.
Yeah, for sure. I've been a nurse for over a decade now, about the same as you. So that's exciting. And nurse practitioner for 3 years. I've been working with gastroenterology and hepatology the whole time. So that's exciting too. I love the field. I kind of fell into it, but it's definitely been a growth curve and I am enjoying myself.
Fantastic.
And
Yeah, I mean, hepatology is very, very relevant. And today, guys, you're in for a treat. We're going to be talking about MAFLD. Now, just to kind of break this ice here, Sarah, what is the difference between metabolic dysfunction associated fatty liver disease and non-alcoholic fatty liver disease? Are they the same thing?
yeah, so funny story. They changed all the names in the hepatology world. It's actually MASLD with an S. So
Geez.
metabolic
Okay.
associated steatohepatitis is MASH. So they do MASH and MASLD now. So that's, I
My
don't know
gosh.
why they've been very harping on this at all of the conferences lately.
Okay.
Yeah.
Yeah. Got to get those terms right.
I guess so. MASLD and MASH. So MASLD is pretty prevalent, especially in the American population. And then MASH is like MASLD, but with fibrosis or scarring. So just higher risk patients that have more scarring of the liver that we need to kind of take a little better care of and try to get healed a little more urgently than people with just MASLD.
Okay. Did they get away from NAFL just because of the fact they wanted to really focus on the metabolic association as opposed to saying just because you don't drink, you get it?
Yes, absolutely. So I think the whole community, by community, I mean like the hepatology community, is really straying away from the stigmatism that is alcohol use. I think
Hmm.
so. Even the word non alcoholic kind of just brings up the word alcohol, which is what I think they're trying to get away from, if we're being honest. But that's completely my opinion. They didn't say anything. They just have been at all of these conferences being make sure that, oh, it's MASH now and it's MASLed now, and that they're saying associated, not alcoholic. So it's been a whole transition, I guess.
Yeah, no, sounds like it. So with now, correct me if I'm saying this wrong. Massled,
Yeah, that's right.
massled. Well, how common is this, and like who's mostly affected by it?
So MASLed would be a third of the American population. And they a lot of times they pronounce it MASLD. So two-thirds of these people that have MASLD or MASLD,
Hmm.
two-thirds would be diabetics, and then the other two-thirds of people that are obese also have it. So two-thirds of diabetics, two-thirds of obese people have
Hmm.
MASLD, and then only a third of diabetics and a third of obese people have MASH, which means they have scarring of their liver that needs to be reversed.
Got it. So, these metabolic conditions far outweigh the number of people who get this from alcoholism. Is that a fair assumption?
I think that's what they're trying to stray towards, is that a lot, especially in America now, I think that these
Hmm.
metabolic associated syndromes, I mean, there's four components of that. It's just obesity, which is BMI greater than 30, which is a huge percentage of people. Type 2 diabetes or pre-diabetes, hypertension, and hyperlipidemia. So those are the top four. And I mean, you could probably not
Hmm.
name a single person in your life that doesn't have at least one of them.
Exactly. No, that's actually completely true. Now, if I was to just look at a basic CMP, like what might I see that lets me know, like, okay, hey, we're kind of starting down this pathway here?
That was a loaded question, Jeremiah.
Was it? I mean, I don't even know. Can you even tell? Like, I don't know.
I mean, just a basic CMP.
Basic.
I mean, the liver function tests are in the CMP, right? So bilirubin, alkaline phosphatase, AST, ALT. Those are the top four that we look at, but they don't really paint the whole picture. Even when you go into like a CBC, so getting like a platelet count, that's important and for your liver disease. If you went into a differential of a CBC, the MCV of a CBC is related to your liver disease because that has to do with the size of your red blood cells, which comes from your liver. So there's
Mhm.
so many components that come from that of your digestion and of your body that come from your liver. It's a fascinating study.
Interesting. Yeah. So you're definitely going to want some more blood work. Are you going to want like clotting factors and stuff like that too?
Yeah, so if you're trying to calculate like a MELD score, right? That's like the hepatology bible to see how badly somebody needs a liver transplant. So that's for
Hmm.
the more severe liver disease patients that we'll have. But really, if somebody just comes into me for like elevated liver function tests, I'm doing a CBC diff, a CMP, an ELF test, which you can get at most labs now. That's a better measurement of fibrosis of the liver or
Mm,
scarring, lipids or cholesterol, total cholesterol panel, and then a TSH reflex to T4. That would be the basic starting labs, I guess.
interesting. Why the thyroid studies?
Well, the thyroid beta cells come from the liver. So you know all about that. You and your
Okay.
mechanism of action.
Okay. All right. That was a spicy way to put it. Hey, so, this is a thing. Let me ask you this. Can someone with a normal body weight, can they develop this disease?
Normal body weight. I feel like that's a loaded question too. Like normal
It is
BMI,
loaded. Yeah. Let's say they have a normal BMI.
like
Can they still have enough risk factors to develop this?
less than 30 normal BMI? Yeah, I mean, like I said, any of the four components, right? So if you still have high blood pressure, that affects your liver. If you still have hyperlipidemia, that affects your liver. And then obviously diabetes. Sometimes
Sure.
people are under 30 in BMI and still have one of those three.
Now, is this reversible? Can people correct this?
Absolutely.
Thank goodness.
Yeah.
Thank goodness. And how, Sarah? How can they do this?
But how? So as long as you haven't gone too far is what I tell people, then we can make it better. Obviously, there's they also I don't know what the is with the number 4, but hepatology loves the number 4.
Sure. That's a round number.
Obesity, yeah, it has great 4 pillars. So 1, diet and exercise, 2, behavioral changes, 3, the medication field, which is growing immensely every day. They're doing different studies to try to find medications to reverse the fibrosis of your liver. And then 4 is obviously bariatric surgery, which is another growing field, especially in America.
Okay. What are some of the I know we've kinda talked briefly just in text and stuff, but what are some of the medications they're using now for this?
No, so really we just talked about, I mean, as far as the guidelines are concerned, they really have only talked about for liver fibrosis reversal. There's just the top
Mhm.
2 medications right now that have been approved by the guidelines from the hepatology, like American Hepatology. Why can't I think of that term?
Yeah, it's there somewhere.
Yeah. Anyway, the 2 medications are resmetirom or Resdifra, which is a medication actually reverses the fibrosis of your liver, and the second one is semaglutide. I know.
Semaglutide, we know all about that, guys. Okay, well, that's good to hear. I was just about to actually segue into what are your thoughts on the GLP-1s and their effect on this?
Everybody's favorite medications right now in this field is the GLP-1s. I think they need a lot more monitoring than I think people are giving them credit for right now. The way that they work is amazing. The semaglutide works great. GLP-1, the tirzepatide I have found works better because it's a dual acting
Yeah,
GLP-1 and GIP, but I don't think people are I think we're prescribing them and then turning people loose too much. Like, "Oh, here, take this."
sure, sure. Yeah, and see, and I'm on the other end of the spectrum. I feel like you should be able to go into any 7-Eleven and just pick this up off the shelf. But, and also Retatrutide is going to come out too. Now that's a triple agonist, right? Glucagon agonist. So we're talking increased metabolic rate. We're turning up that thermostat. I mean, in studies, it's outperforming tirzepatide and semaglutide significantly. Can you get it from the black market, gray market? Absolutely, guys. But fact of
Yeah.
the matter is none of the pharmacies carry it at this point. But when they do, it's going to be it. And you know what? Will I try it? I don't know. I'm nervous because I'm on a fairly low dose of tirzepatide. And when you take something like retatrutide, you're way up here. You can't come back down. Like tirzepatide will never be the same. So for me, I'm like, if I can get away with tirzepatide, I've been on it for over a year. I love it. I don't know if I'll ever try retatrutide, but I know people that are on it and they are killing it, killing it.
You know people that are on this new medication that isn't out yet?
Yeah, I know people that are in the medication that's in phase 3 clinical trials right now. They're currently on it, not in the clinical trials, and they're killing it. This stuff's
Wow.
more available than you think. You just type in retatrutide in Google, you're going to find some kind of online market to buy it. It's out there. And of course, there are clinics that are prescribing it and stuff like, I mean, I don't want to say prescribing it because you can't prescribe it, but there are clinics offering it. But what you have to realize is this is a non FDA approved medication. You just have, that's what it is. Can you get it? Sure. Should you? No, you're rolling the dice, but that's everything, right? Every time you step into your car, you're rolling the dice. Now, as far as the medications, like, is there like a specific order you do them? Like, hey, this is first line, this is second line. Do you escalate it?
Yeah. So, I mean, I think in your space is so much different than my space because you're very focused on like hormone therapy and you're more you're able to focus more on like weight loss than I am in the GI
Totally.
space. A lot of times I have to focus on the side effects of these medications.
Clean up the messes or
Yeah. I'm having to clean up the you got dope with this and now you can't stop vomiting.
cool.
Yeah.
Thank you.
The very severe cases of pancreatitis that we've had in the hospital, and people just don't understand that this can happen on these medications. And I think that we like to put the silver lining on it. Like you can lose weight and you can do well, but you have to change your life while you're doing it. So I think that's important.
Super.
The other
Super.
medications that I wanted you to look at though is like they're coming up with some. I wanted some mechanism of actions for you. The FGF21 analog. Have you heard of those?
Wow. FGF. I have not.
FGF21 analog. So they improve your lipid and glucose metabolism, reduce your liver fat, and actually can decrease the fibrosis at the same time. So it's like doing all of the things at once, which is kind of crazy. And
Yeah.
that's
Sounds like a
also
miracle medication, honestly.
right.
Yeah.
I know. So they're testing that currently. I guess Roche picked it up. That's a big pharmaceutical company. They have pan PPAR agonists that are coming out. They reduce fibrosis as well, and more importantly, they're reducing pulmonary hypertension, which
Wow.
is another big problem for
Hmm.
us in the GI hepatology space.
Really? I didn't know that.
Yep, so they're testing that one, and then, the oral GLP-1s, obviously, they're not
Mhm.
testing those, they're trying to come out with them in the I bet they'll be out all over in the next, like, year if they're not out right
Sure.
now. I think people are
Yeah.
prescribing them now.
Yeah, yeah, absolutely. I bet. You bring up a really good point about a lot of people getting on these GLP-1s and just using it as a crutch. And this is the reality. The person that does incredibly well on the GLP-1s is someone that's already built a foundation. They've already made those lifestyle changes and they're using this as a tool because it's a very powerful tool, but it's not a map. It's not going to tell you what to do. And sure, can you take this, suppress your appetite, get severely dehydrated, malnourished, plethora of problems? Absolutely. It happens all the time, unfortunately. But I agree. When you get on this, it's really important that you're working with someone that can at least tell you how to use this because intuitively you think, oh, I take the shot and I lose weight. How easy could that be? There's nothing easy about this process. Nothing's easy about progress.
Yeah, absolutely. I think as far as, like, prescribing weight loss medications too, I try to figure out which one's gonna work better for a lot of these patients, like the GLP-1s versus the dual acting, the tirzepatide versus, like, we're still using phentermine and topiramate a lot of times for people.
Mhm.
And then I just listened to a brief. There's a lot of people still using like Contrave, which is one of the oldest like appetite suppressants there are. So I mean, it kind of depends on what the problem is for the patient. I think it's important when people come in and want help with their obesity and help with their weight loss, being like, why do you think you are overweight? And being able to talk about that in a sensitive enough way that you don't offend people has also been a challenge.
And it depends on where you're at, right? In a place like mine, people are very forthcoming with, "Hey, I've struggled with weight loss my whole life. It's always been purging and binging and all these other issues." And there's a lot of psychological aspects to it as well. We really tie our self-worth to how we present ourselves, our physicalities, whether or not that's right or not, it happens. And so I agree with you 100%. It's always important to individualize what works best for a specific person. But in my experience, tirzepatide is just superior to semaglutide. Do people still thrive on semaglutide? Absolutely. You can thrive on any of them. You can thrive off of any of these. Believe it or not, guys, you could diet and exercise without them and do just fine too. This is really just something to make it easier. And people hate to hear that. They're like, I don't, it's cheating. I don't like the easy way out. But the reality is if you don't like the easy way out, then stop driving to work, walk. I mean, we have these tools, we can use them. It's one of the benefits of being in a developed country. The downside is we're being poisoned with preservatives in the food and the fluorides in the water and BPAs. And I could put my tinfoil hat on all day, but the reality is you got to take advantage when you can. Now, if you were to see someone who had massled and you're like, okay, these are the things you need to adjust in your lifestyle to improve or reverse this, what are those key points?
I think in my experience, talking to people about their lifestyle is always the first thing. I ask people, what kind of things do you eat? And usually their answer is very generic, like, oh, I eat really well. I'm like, okay,
Mm,
I need you to tell me more. Like, what does that mean? Like, what does really well mean to you? Because I'm finding that a lot of times people think really well means processed foods only once a day,
yeah,
once a month,
right, right.
food only once a day, not once a month. Like these types of things, I think that as a society, we've kind of done that. And then like exercise, right? What kind of things are you doing for exercise? Just being more specific about it because I think as an APP, especially, I have the time to talk to people about these things too. And I think that helps where doctors don't really, they have like 5 minutes with the patient and that's all they get. I think that's hard.
It is hard, but this isn't something that was ever covered in the curriculum. During our education, whether it's NP, MD, we talk about this on a lot of podcasts. You don't cover this stuff. And the reality is how many healthcare professionals do you see that are unhealthy? And they're preaching, hey, you know what? You got to do ABC. And it's like, well, it doesn't look like you take it that seriously. You know what I mean? You kind of have to live it to really convince people to do it.
That's true. That's so true.
Yeah, and so I've heard some people say like, "Hey, you know what? There are certain diets that work better for reversal of these kind of conditions." Like, do you think Mediterranean, keto, is there any specific diets that you guide people towards or recommend?
Absolutely. I guide people toward the Mediterranean diet every time. It's been the number one diet in America for more than 20 years. I think it's the most universally accepted. Yes, keto works better for some people. Yes, there are other diets that work better for other people, but Mediterranean's going to work for the majority of people the majority of the time. I have found.
Yeah, absolutely. Absolutely. And when it comes to like specific types of exercise, do you tell them, "Hey, weight training versus cardio or does it matter or get X amount of steps?" What's the general rule on that?
I have, again, I feel like a lot of times I get to start people on this journey, but I don't get to continue the journey with them. I've been doing this 3 years and I probably have only had like a handful of people that have stuck with me the whole time, whether it's because they got busy and fell off of my charts or I sent them to you. I have done that before.
Yeah.
So I don't
Yep.
always get to like see that progress. So that's a little bit frustrating. What was the original question though?
Cardio or weight training, which
Oh,
one's
yeah.
better?
So I always am like, listen, you just need to move more. Either move more or change your diet. I always tell people don't do both at the same time. If you're
I love that.
here, yeah, if you're here and you're morbidly obese, you got to pick one or the other. And once you get good at one, then you can pick up the other. But I find that if you try to do all of it at once, it's too overwhelming and that doesn't work.
Yeah, I really, really like to hear that. That's really refreshing because you're right. If you bite off too much, you try to make too many changes at once, it's not going to stick, right? You have to get that positive reinforcement from one thing before you move on to the other. And at the same time, you're stacking these habits. You show yourself, you know what? I've been eating healthy for a couple months now. I have this down. I'm going to go ahead and start exercising now. You've already
Absolutely.
put yourself in a great place to start. Stacking these habits is the way to go. If you try to do everything at once, like a New Year's resolution, there's a reason they do not work out.
Absolutely.
And my general thought on it is, you know what? Build as much muscle as you can. Build as much muscle as you can. That's the
Of
number one
course it is.
disposal of glucose. That's where your glucose gets stored. If you want to live longer, you want to be harder to kill, build muscle. It's the most important thing. And I tell everyone, hey, most of my guys on TRT, if you're not going to the gym and you're not doing weight training, you're doing yourself a disservice. My women who need to preserve bone density, hey, if you're not doing weight training, you're doing yourself a disservice. Cardio is great too, guys, but we gotta weight train. It is so important. It doesn't have to be crazy. I mean, even sometimes I'll have women just wear a weighted vest around the house. That's enough. You just got to meet them where they're at. But weight training is so incredibly important and build as much muscle as you can to carry you through the rest of your life. And you're going to live a longer, healthier life. Now,
That's great. Meet them where
yeah,
they're
that
at. I like that. That was good.
meet them where they're at. Now, are there specific red flags that you might say, like, okay, these are what I want you to look out for if someone's dealing with MASLD?
I don't see a lot of MASLD. I see a lot of MASH.
Okay,
So
sure, MASH.
I see patients that are already high risk. They are either cirrhotic or they're so
Mm,
close to cirrhotic that you don't want to tell them they're cirrhotic yet because you're worried that it may freak them out. So usually for the cirrhotic patients, it's a little more serious, right? Are you having abdominal pain? Are you having signs of GI bleeding, confusion? Those are the top like three that I stick to as far as like these are really important things. For the MASH patients that aren't cirrhotic, abdominal pain, I'm finding a lot of times is prevalent in them. So just trying to make sure that we know what that the abdominal pain isn't something more serious. Like if you have gallstones, right, and you're having right upper quadrant abdominal pain, and you need your gallbladder out, and you're an F3 liver patient, then we need to get your gallbladder out. I mean, that's something that's pretty emergent because you're progressing into something more serious. And when you become cirrhotic, you're a higher risk for surgeries. Those are kind of the warning signs that I stick to for F3, F4 cirrhotics and swelling. Sorry, I forgot swelling. I knew there was four. I'm telling you, the number four, it's a whole thing.
Love for, yeah, it's a square number. Let me reframe it. So what should a primary care, let's say they go to their primary care, like what are the things the primary care may want to look for to say, hey, I think it's time that we send you to Sarah because we're not liking what we're seeing.
Yeah, I think that it gets missed a lot, but abdominal pain, swelling that isn't cardiac or pulmonary, right? I mean, because those can cause swelling too. But a lot of times, like that inflammation or any type of GI problems, people come to me with GI problems and then it turns out they have a liver problem. That happens a lot too. So those are the top three I'd say for primary care. Inflammation's a big one. If you don't have an explanation for your inflammation, at least look at the liver to run some liver function tests, and they're going to be elevated almost always in these MASLD patients.
Sure.
Yeah, some form of elevation probably.
Do you think as far as consults go, it's typically delayed, or do you think that from what you see, because you see these in later stages, you feel like this people could be a lot better about being proactive with getting consultation sooner?
Absolutely. I think nobody wants to have the conversation that you have fatty liver disease. I get those consults all the time where they're like, "You have a fatty liver, go." And I'm like, "Well, what did they do for you?" And they're like, "Nothing really. They just said that my liver was fatty and that was it." And again, the word like fatty liver is just so generic that I think that we're doing patients a disservice by not sending them over sooner or talking to them sooner about kind of what's going on.
What are some of the other testing that they do? I know like they have fibro scans and they have ultrasounds, biopsies. Like what are some of the tests that they do to confirm these diagnoses?
Yes. So diagnostically, to stage your fibrosis or scarring, we definitely do the blood work and the ELF test, which I think that primary care could utilize a lot more. An ELF test, ELF, ELF. That's a fibrosis test that you can order at Quest or LabCorp. Most Quest or LabCorps. And if you can't get it like if your insurance won't pay for it, there's actually reimbursement programs through those companies that make the medications that they want you to use to reverse your fibrosis. Also, Novo Nordisk
Mm,
and Madrigal, who makes Resdifra, they have programs
okay.
where they'll reimburse you for those ELF tests if you start using them. Sorry to go off on a total tangent, which seems to be my thing. So the blood work is important that we talked about earlier, and then ultrasound and then fibroscan is a special type of ultrasound that actually looks at the liver cells and how stiff they are. The stiffness of your liver cells kind of determines how much scarring or fibrosis that you have.
Hmm. Are there some genetic components that play into this too? Are some people more just genetically, predisposed to having this?
Yes, absolutely. I also do with my elevated LFT patients an alpha 1 antitrypsin test, which isn't typically something that people are doing. Alpha 1 antitrypsin deficiency is something that puts you higher risk for cirrhosis already. So that's just one like genetic component. Obviously, if you have obesity or diabetes in your family, those are things that can also put you higher risk for fibrosis of your liver. I mean, diabetics, this is the diabetic capital of Colorado, if we're being honest. So
Absolutely. Yeah.
anybody that's Hispanic or African American, you're already genetically predisposed to have liver fibrosis. That's just the name of the game.
Yeah, I wake up every day and I'm like, not today, thank goodness. Okay, we're gonna flip the script a little bit here. So we're going from hormones happen to hepatitis happens. And Sarah, I'm gonna have you ask me a question. Yeah, I know. I didn't even prepare her for this. She has no idea what to ask me. Anything. Hormones, weight loss.
Well, I was not prepared for this at all, sir.
I know. I'd put you on the spot.
That was
Told
terrible.
you I wasn't, and I did anyway.
Yeah. Okay, when your patients come in, do you always ask them, I mean, how do you start deciding what kind of weight loss program to put them on?
Sure. For me, it's pretty simple. I'm a huge advocate for tirzepatide. I'm a huge advocate for the GLP-1s for other reasons than just weight loss. Weight loss is fantastic, but the improvements in, metabolic health, decreasing insulin resistance. I have young, healthy athletes on GLP-1s. Um, you know, I think that GLP-1s are an amazing medication for a multitude of different purposes outside of weight loss. Frankly, I mean, do they do well at weight loss? They do great, but you have to have the right mindset. I don't necessarily like the fast, rapid weight loss that is associated with them. We even have things like Ozempic face. I heard Ozempic neck, like just this stupid shit that people come up with.
Real.
And it's just fear mongering. I mean, it can be real, right? But that's any kind of rapid weight loss. So for me, really, I educate them on the difference between, because we offer semaglutide tirzepatide. We talk about the difference between a GLP-1 agonist, GLP-1 with a GIP agonist, and then I let them make the decision. And usually the deciding factor will be their budget, will typically be the cost. So, and that's okay. I mean, the reality is these medications aren't necessarily cheap. I do hope in the future it comes to a point to where it can be accessible for everyone. Insurance will start covering this for just about anyone, and it'll be very affordable for cash pay. I really hope that that's the future, because we're really kind of cleaning up a mess that we've already developed. And you develop these addictions at a young age. I mean, how many of us grew up eating Lucky Charms, Fruit Loops, and they called it cereal for breakfast? And how can you not have a sugar addiction later in life? Like, it's just, we're being set up for failure, and now we have something that can help to fix it, and we're kind of being price gouged and stigmatized. And I don't know where we're going to go with it. I just kind of go day by day. But there's nothing more rewarding than having someone reach out to me saying it's absolutely changed my life. I feel better. Anxiety is much better. I hear that all the time. A lot of women with their perimenopausal symptoms feel so much better. Fertility improves too. It has a lot of ovarian support. And then, of course, decreased insulin resistance and metabolic disease. These are as close to miracle drugs as we can get, but it's important to know it's a tool. At the end of the day, it's a tool, and it's only going to work if you work it. So that's really about it. That's the conversation we'd have. If you called me, text me, that's what that conversation would sound like, because I put you in control. I let you choose. I don't say you can't be on this. You have to be on this. No, I mean, I would say one thing that would take into consideration is semaglutide does have a slightly higher chance of hypoglycemia compared to tirzepatide, just because of the way that it regulates glucagon release from the liver. So if you're on other diabetic medications, that might be a consideration we think about. But ultimately, I think we deserve to have a say in our healthcare. And I take that very seriously.
Those are really good answers.
So, Sarah, in closing all this, what is one thing you want to let people know as far as, hey, if I'm concerned about this is something that's weighing heavily on my mind, what should they do tomorrow?
Dr. Azar says only you can control what you put in your mouth.
That's true. 1,000%. I agree with that.
He says it every single day. Only you can control what you
Yeah.
eat and drink every single day.
It's like Smokey the Bear. Only you can prevent forest fires, right? Only you can prevent liver disease. Okay.
True. I
Yeah.
did have one more hormone question, though. Can I ask you another question?
Of course you can. Yeah, of course. We're still in hepatitis happens.
Hepatitis happens.
Yeah, that's your podcast.
I have two things. One, it would really make my job a lot easier if primary care providers would 100% of the time, after getting elevated LFTs, check for viral and autoimmune, well, at least viral hepatitis.
And how do we do that?
A lot of times there's like an acute viral hepatitis panel you can order, or even a chronic viral hepatitis panel. Hepatitis happens. Speaking of viral hepatitis B vaccine. Has
Yeah,
anyone been talking about this? Because my head is getting
right.
ready to explode.
No.
It's bad. Hepatitis B is not curable. You can't cure it. And you can think whatever you would like to think about vaccines. I have no opinion on everybody else's opinion. Medically, I do not want to treat hepatitis B patients 10 years from now, 20 years from now. It's terrifying. So, hepatitis B vaccines, look into it. Look into what hepatitis B is, how you can get it, and just
Huge. Yeah.
we should be testing for it more, especially as these vaccines get more scarce.
Okay. I love it.
So yeah, the viral hepatitis question, that's something that PCPs can test for. And then the question I had for you was about the thyroid. Are you not testing people's thyroids when you're seeing them for weight loss?
No. No,
Oh,
it depends. We can. This is the thing. We can test for anything that they want specifically, but we really defer a lot to their primary care providers. So, I assume that they have a primary care provider. We can always get labs. I'm more than happy to get labs and explain several things for them. But as you know, weight loss is very encompassing. There are so many different factors to it. Thyroid can be huge. Hormones can be huge. And once again, you got to meet the patient where they're at. At what point do you draw the line between, hey, we're a hormone weight loss clinic and a primary care clinic, right? And
sure.
so that's really kind of where you have to differentiate and delineate, because there's a lot that goes into it, right? Like, let's say you want a full workup of that thyroid, right? We're going to need to start palpating it, ultrasound if there's a nodule, potential, fine needle aspiration biopsy. There's a lot of things that go into it. So, checking the thyroid, cool. But then what do you do when it's not good, right? They go right to their PCP. So, the reality is depending on their symptoms depending on their intake forms and stuff like that. We can usually kind of differentiate some things. And have I had some people, and this is more so with hormones, have I had some people come in who have these really vague symptoms and it ends up being, it's not, I think there are some other problems other than hormones causing your issues. Sure. Low ferritin levels in women who have very heavy menstrual cycles. I see it all the time. Get that iron up. Guess what? You feel like $1 million again. It wasn't hormones yet. And so the reality is it's very complex, but once again, I offer it. Because worst case scenario, let's say you take it, doesn't help, doesn't do anything. Okay. Well, that was, diagnostic too, right? Didn't work. Something else is wrong. But yeah, that's my thought process on it.
And then, like, the psychological component of weight management. Are you honestly, just because I'm also practicing in the same area as you, are you referring people to, I mean, who are you referring people to? Because I feel like in this area, it's just so hard to find good support.
For psych,
Yeah.
no, I haven't referred anyone to anything. And I agree, it is kind of scarce, but just 'cause someone's overweight, I don't typically tell them they need to go seek
Well,
psychiatric
no,
treatment.
that's not what no, I just mean, like, if people are having a hard time, I mean, we need to take that into consideration, their emotional health, and I think that's something that's easy to dismiss, but also, like, should we be sending them somewhere? Should somebody be talking to them? Obviously, I'm not qualified to do that, and you're not gonna take that on either, so, I
Hey,
mean, what do we do?
I like to be very supportive. I reach out frequently, and whenever we have a small win, they're like, "Hey, I lost 3 pounds." I'm like, "That's fantastic. That is really good." And I be sure to emphasize this: it's not the medication that lost those 3 pounds. It was you. You did that. You're doing a fantastic job. And if you just build people up, you give them a better opinion of themselves, they're going to do better because we have a habit of forming an opinion of ourselves based on what other people think. We let other people determine our value, determine our worth. And if you are around people who are very positive and very supportive, that's a great circle. If you're in people who are just very dismissive and they're very negative against your goals, I mean, you're never going to thrive. I tell you to get rid of that circle, go to a new one. And so I do feel like, and I can't guarantee this, but I assume that with my positive behavior and supportive nature towards just anyone who's trying, I think it helps. I think it does. I'd
Yeah,
like to think so at least.
I
Helps me
agree.
sleep at night.
You've helped me.
Hey, that's it. I help myself. I help everyone I can, because the reality is, it shouldn't be this hard. It shouldn't be this hard for us to just try to live our best life. I really do wish in a perfect world one day, I'd like to think that we have full access of our healthcare and it's affordable and we can be on the hormones we want, we can be on the medications we want, and we're able to make these decisions on our own with guidance, not dictation from medical providers. But who
Yeah.
knows? Who knows what'll happen? But I definitely appreciate everything you do. There's no doubt about it. You do a fantastic job. And I'm really happy you came on the podcast. Do you have anything you'd like to say? Any closing words?
I have I just love hepatology. I think it's amazing. I think that the liver's amazing. It can do so many good and bad things to the human body. And I think people need to know more about it. And we take it for granted. It heals itself until it doesn't anymore. So it's important for us to take care of it and for us to take care of each other. And I think the more information we have as a general public, the better, because that's what we do, right? Education is power. Knowledge is power.
Knowledge is power. Awesome, Sarah. Thanks for joining us today.
Thanks.